Well, good afternoon, everyone. This is really exciting for me. This is the first Transform that I've been a part of, and I want to thank the organizers for inviting me. It's really a daunting challenge to kick off Transform on NFL kickoff Sunday. The Vikings are ahead, at last I checked. And it's really hard to kick it off on a topic when I'm supposed to excite you all about dying suddenly. That's a tall order. But what I want to share with you is hopefully the fascination of this topic of sudden death in the young and what's being done to prevent youthful sudden death and to explain sudden death. Now, I'm a conflicted individual. These are the conflicts of interest to disclose. More importantly, I think, because these don't really matter to the topic at hand, are these disclosures. I own no stocks and I love my wife. And most importantly, I'm conflicted with a profound interest in saving lives. I'm interested in saving lives of all people, but for the topic of today, we'll just say most interested in saving the lives of young people, arbitrarily defined as people my age or younger. So that'll be the definition of youthful sudden death. Now, when we think of deaths in the USA, we are aware of this huge epidemic of sudden death, mostly in the elderly, nearly 300,000 deaths each year. We're not going to be talking about that. We could be talking about deaths due to car accidents, 42,000. We won't. Or a few years ago, H1N1. Or the fact that every year, 3,000 infants fail to reach their first birthday. Instead, we're going to be talking about sudden death of athletes, which you would think is a huge problem if you look at ESPN, but it's not. Each year, about 100 athletes die suddenly. Of young people, about 5,000 to 1,000 young people die suddenly and unexpectedly. But when those deaths occur, they grab us in ways that really challenge our thinking and challenge survival of the fittest kind of thinking, because Hank Gathers just should not have died 23 years ago at the age of 23. 20 years ago, the death of Reggie Lewis caught our attention. And we have the deaths not just in the United States, but abroad in the real football, as some would say, in soccer a decade ago. And here again, soccer the following year, Minnesota Wild lost one of their professional hockey players. And when these kind of deaths happen, even though they're one-ofs, it seems to grab a community and a people in a way that says, how can that be happening? That just should not happen to people who have spent their lives becoming the fit of the fittest. And now with the NFL kickoff, a few years ago, we lost great outside linebacker for the 49ers and Damian Nash, running back for the Denver Broncos. But it's not just professionals. Just 2 years ago in high school, we lost Wes Leonard. And as some of you saw on the news, just 5 days ago, we lost Jenna at the age of 20 in a college cross-country race. And again, these deaths shouldn't happen, and we see those, and they capture our attention like it did in 2004 for Mr. Mayer, as I showed you here. Now look here. He's running to the sideline, number 29 for Mr. Ferrer, and he did that little check. That seems rather innocent, and yet he gets a yellow card for that infraction. And this is quite a reaction to getting carded with a yellow card. And you see these, and you say, how can this happen? Why did it happen? How do we prevent it from happening? Because when it happens to young people, and when it happens to athletes, it grabs us in ways that few other deaths grab us. We see we're traumatized by deaths during war, but we expect that that's war. We don't expect a sudden death on a football field, on a soccer field. And so we try to understand the why. And when we look at the why of these sudden deaths, when a medical examiner looks, about 2/3 of the time we get an answer. The autopsy is positive. They can tell us the reason why. About 1/3 of the time, at least 1/3 of the time, the autopsy is stone cold normal, and we're left with no clues. Let's take a look briefly on autopsy positive sudden death. What claimed that soccer player's life 9 years ago? Well, the answer is it was one of these genetic heart muscle conditions known as the cardiomyopathies. But behind each of these necropsy slides and these autopsy specimens of a heart is a life a life that was tragically cut short. It's families as represented by this one that I've had the privilege of taking care of. Now, this isn't the family photo. This is just a photo that I lifted from Good Housekeeping. But it represents a family that I take care of and have had the privilege of, although it's tragic. Perfect family, 2 boys, 2 girls, everything great, until everything changed at the age of 8 for Chase, who died suddenly and unexpectedly in Sunday school, of all places. Why? Well, the medical examiner gave us the answer to the why. Here's Chase's heart. Profoundly too thick. Her muscle was programmed to become thicker than normal, called hypertrophic cardiomyopathy, one of the most common causes of sudden death in athletes when the autopsy is positive. Now, Chase's family would get the right study, the right exam, which is to get a screening ultrasound of the heart to see who else might have evidence for hypertrophic cardiomyopathy. And the answer is her father does. Never a symptom in 40+ years of life, yet he has the disease. Baby brother does as well. At age 18 months, he was found to be far thicker than normal. In fact, the baby brother got an external defibrillator rescue when he was getting out of a bathtub at age 2. From age 2 to 6 then, he got implanted with a defibrillator, which rescued his life 12 times from the fatal rhythm of ventricular fibrillation. And truly, episode number 13 was tragic because his own internal defibrillator failed to rescue him. Now the family comes to you and I with a very different question, which is, how sure are you that our 2 children whose echoes are normal do not have the family curse? That question brings us into omic medicine. And the day of genetic medicine is upon us, has been upon us, thanks to now 10+ years with the completion of the Human Genome Project, where on the 10th anniversary now, we celebrate the fact that at the price point of a buck of nucleotide, this has been declared one of the greatest feats and accomplishments in the exploration in history. That is the inward voyage of discovery. And it's brought in and ushered in genomic medicine, where we can do genetic testing for a whole variety of diseases. And that's exactly what was done for the rest of Chase and her deceased brother's family, is to try to find the X that marks the spot, the root cause, the smoking gun for their disease. And here's the answer. It's quite staggering when you think about it, isn't it? Out of 3 billion nucleotides of genetic information for Chase and her father and her baby brother, the result is here. 1 misspelled letter provided the fundamental substrate for the family disease that predisposed them to sudden death. And equipped with that discovery, we're able to answer the question, that mutation that disrupts a critical contractile muscle element in the heart, alpha-tropomyosin, we can use that as the gold standard biomarker for this family. Maybe never use it again for another family because this is their mutation and their own mutation. But use it we can because the guidelines tell us that we can do this thing called mutation-specific genetic testing. And look at the impact of this discovery. Her living sister is dismissed, soon to graduate from high school, did not inherit it, cannot show it, cannot pass it on, dismissed. Her brother is positive, and he was diagnosed in a pre-disease state, and equipped with that information, the family elected to get an implantable defibrillator, and over the past 10 years, he's been rescued 5 times from ventricular fibrillation, with the first episode occurring before the disease even showed hypertrophy of the heart muscle. Kind of a wow impact that genetic medicine can have. What about for autopsy negative, when the medical examiner, the coroner, says, I don't know why? Well, we can address that as well to answer a mother's question that was posed to me several years ago. Does my 13-year-old son have what killed my 17-year-old son? Perfectly healthy, Shannon was, dead in bed at age 17, the autopsy completely negative. Despite that, the coroner of that county and the local newspaper were sure they knew the cause and manner of death. In fact, so much so that they wrote an editorial in the local newspaper called "Parents, Talk to Your Kids." Conclusion, it had to be drug use and abuse. Well, the mother was not satisfied with that expert opinion, and she sought several others. In fact, we were institution and physician number 5, and we elicited a clue that the mother had fallen from the top of a 3-meter diving board some 30 years prior. And we reacted to that clue and the death of her brother and said, no, not so fast. I don't think this is drugs. I think it's going to be one of those heart diseases. We evaluated the mother. Nothing showed. We kept evaluating with a new test that we developed at Mayo called the epinephrine QT stress test and found a signal. And with that, we went to the mother's genetic code, and we would find the cause, a disruption of the gene that encodes a critical ion channel of the heart that controls the heart's electrical system. And mutations in that gene give rise to this disease called long QT syndrome that affects about 1 in 2,000 individuals. And now we would have the answer for this mother. Does my 13-year-old son, by the time we discovered the answer, now 14-year-old son, have what killed her older son? Answer is yes. Past 14 years, he's 28 years old now, alive and well, and one saved from his defibrillator. So when we know these diseases are there, we're actually very good at preventing a tragic sudden death. But there are challenges. We had to study the mother as a surrogate because the medical examiner did not procure tissue in a DNA-friendly way. And so we need to work on this. We need to make standard procedures that when there's been a death that's unexplained, that tissue is procured in the right way so that we can even have a chance to ask the genetic question and do the molecular autopsy that we developed and first performed at Mayo over 12 years ago. Because this kind of source will not work. Tissue is the issue. Paraffin-embedded blocks, which is the standard practice in medical examiner's office, will not work very well. And instead, what we need is a blood spot card or blood in EDTA or frozen tissue. We have work to do to get this to happen. And more importantly, there is tremendous heterogeneity across the medical examiner, coroner community in terms of the sophistication to evaluate sudden death. After all, their job description is to rule out bad behavior. And they do a very good job of ruling out homicide and things like that. Not as good and quite variable if the death is inconclusive or they're not finding something. So the quality of your autopsy will depend on which county you reside in. Some counties, all you'll get is condolences. Other counties, you're going to get no stone left unturned examination and search for the cause, even if the cause appears to be natural. In fact, one of the best places to die suddenly, or to try to die suddenly, is Rochester, Minnesota. Number one, it's really hard to die suddenly in this city because we have one of the fastest response times in the United States to get an external defibrillator to you. And two, if you do die suddenly, you can imagine the hounds of heaven will be upon it to figure out the truth. What is the cause? When we find the cause and when the coroner preserved tissue in the right way, we've been able to do such a molecular autopsy for these 173 tragedies. And you should know that despite a negative autopsy, we can find the truth about 25 to 30% of the time. That is, mutations in genes that control and encode proteins that govern the heart's electrical system, like the ryanodine receptor as shown here, and a mutation that explains the death of this 17-year-old, the deaths of this 5- and 4-year-old, the death of a 17-year-old and a 14-year-old, a 2-year-old who died suddenly while watching TV. Which, by the way, the American Academy of Pediatrics has used this observation of ours to buttress their campaign to minimize TV watching for toddlers. Not only is it of no good, it'll kill you. And so they've taken full advantage of this piece of information. And then this 34-year-old giving speech, which I imagine in the future we will probably have to have our ryanodine receptor scanned to verify it's clean of any mutations before we're allowed to give a speech. One of the other challenges, we know the cause of death for these individuals, but sometimes it's not so easy. Sometimes the finding that the X that marks the spot is the wrong spot. In other words, how sure are we that what we found is the cause? We better be really sure if we're planning on screening the rest of the family for it. And it turns out that we're not always as sure as we think we are. In fact, I illustrate here with the sodium channel of the heart. This is a protein that contains over 2,000 amino acids. And here are putative mutations scattered throughout it in patients with a 1 in 20,000 disorder called type 3 long QT syndrome. Here are other mutations scattered throughout it, found in patients with about a 1 in 20,000 disorder called type 1 Brugada syndrome, a different potentially lethal heart rhythm disorder. And here are similarly rare mutations found in one of 1,300 I'm a healthy blood donor. In other words, rarity does not equal causality. And we got misled a little bit about that. We've been making fumbles for the last few years thinking that it's easy to decode our genetic code when it's not so easy and straightforward. Just this gene that encodes just this protein alone, if you have rare things that localize to that rectangle, all we can say that these are maybes. Maybe yes, maybe no. Well, for life-threatening heart diseases, we need better than maybes. And so we have this issue with genetic testing that we need to work through, we need to get smarter about, and that is dealing with the maybe test result. Now, the genetic test almost never says maybe. Instead, it's cleverly coded with words like possible deleterious mutations or a variant of uncertain significance. That's not what I call it. I call it genetic purgatory. You're stuck when you get a maybe. There's work to do, and yet most individuals who are ordering genetic tests don't realize just how much work there is to do. What was the index of suspicion? Have we done our homework? And more importantly, they need to become a believer in the first place. That is, we need to realize full well that genetic purgatory is a real place, and it's scary. And we are fumbling the ball with respect to interpreting our genetic code. So let me leave you with 3 take-home points and 3 challenges as we close. First, I hope you've realized that youthful sudden death really rivals elderly sudden death in terms of lost life years. Second, that 35 to 50% of the time, that sudden death will be associated with a negative autopsy, even if that autopsy was done perfectly well. And third, when that autopsy is negative, we can find the genetic truth about 25% of the time, with mutations in the genes that encode the ion channels of the heart. The challenges: whose eyes are staring at the sudden death victim? Do we have the right kind of DNA-friendly tissue procured? A lot of work to be done in that area. Second, we haven't really talked about this, is the cost issue. If health insurance companies are increasingly reluctant to pay for things when we're alive, they really don't like to pay for things after you've died. So we have work there to do to extend the date of coverage beyond the date of death, because it may be the most important test for the rest of the family. And third, decoding our genetic code is not so easy. X does not always mark the spot. And we have to solve these challenges for the sake of the families that I take care of, like Dalton and his family. And I close with this letter from Dalton's mother that really shares and expresses why we do this anyway and try to get smarter about these conditions to explain sudden death and, more importantly, to prevent sudden death. And I close with Teresa's letter with her permission. My name is Teresa Brown. I'm the mother of a 2-year-old daughter, Dalton, who died of an unexplained sudden death in May 2001. I'm writing to thank you and commend you on your work in this field. I received a call from Carla in your office notifying me that a gene mutation had been found in my son's heart tissue. I had been told by our coroner's office that the genetic testing required to determine if my son's death was caused by long QT syndrome was too costly to perform, for them to pay for, I should say. I was also under the impression that very few cases were actually chosen for research. I had no idea over the last 3 years that someone was still working on Dalton's case. I had given up all hope of ever getting a medical explanation for his death. When I received the call from Carla, I was confused, shocked, and thrilled all at once. I'm sure you know from your career choice that the death of a child is always unbearable. When it occurs in a happy, healthy child for no apparent reason, it is even worse. People are always shocked to hear that my son died, and they always ask what happened to him. I would cringe every time I knew that question was coming, because having to say, I don't know, he just passed out and died, was its own living hell. I longed to be able to just say cancer, leukemia, heart attack, or anything besides I don't know. You had given me the greatest gift, and I would like to thank you from the bottom of my heart. Your research and testing may even save the lives of other children in our family, and that is priceless. Thank you so much for choosing his case for research. And I thank you so much for coming to Transform 2013 and for letting us launch this with Dalton and stories like Dalton's so that together we can make a life-changing and a life-saving impact. Thank you very much.
Two quick things, and I'm thrilled to know that the Sudden Death Response Network is fully activated here in Rochester for all of us here in this room. I'm feeling very comfortable, that's for sure. And for those of us with public speaking anxiety, we could actually have a genetic screening to determine if it's unsafe for us to be up here.
Yeah, it's 1-800-RYR2 screen.
Nice. All right, let's talk about Dalton's mom for a moment. She's relieved. But scientifically speaking, does she know the answer to the question of why her son died?
Yes. So from a scientific standpoint, we've been able to reconstruct, obviously with the mutation that was discovered, that it's a root cause in one of the critical proteins that govern his heart's electrical system that gives rise to a specific disease. Now, there's always going to be that step of faith to say, did he die from that mechanism though? But in this situation, all the things have lined up to where we have a pretty much rock-solid argument to explain his cause. It's not a maybe
in this case. All right. Then if there is sudden death in a family and there are other siblings and family members, is it not standard of care or standard of care to do genetic screening if there's a negative autopsy to determine if there's some abnormality?
Yeah, right now, unfortunately, there's no standard of care. There's no standard of care of how sudden death is evaluated in the United States, period. So in one community, you might get every evaluation under the sun of the deceased and of the living relatives. In other communities, the most you might get is a sympathy card. So there's really, that's one of the areas that nobody talks about in medicine, that the death evaluation, the unexpected death evaluation, is so grossly heterogeneous across the country. We've got a lot of work to do to close that gap.
Well, it's recognizing those gaps and recognizing those questions that haven't even been asked that Transform is all about. Doctor, thanks so much.
Thank you.